Hi everybody, welcome to our Facebook Live question and answer. I'm Dr. Rami Kaldas of the Kaldas Center. I am glad for our new visitors to be here and for our return visitors to be coming back to visit with us once again. We are looking forward to answering your questions tonight. So at this time of year during the holidays, things can get a bit rough when you're struggling with fertility issues. It's hard to find that holiday cheer when there's such a prevailing, overriding concern in your life. And tonight we'll be talking about infertility and how to cope with it during the holidays. However, please feel free to ask any women's health questions. I am glad to answer them or direct you in the right direction. Thanks to everyone who submitted questions on Facebook already. If you have not sent in your question yet, feel free to post it to Facebook Live and we will do our best to answer it tonight. If you would like to submit an anonymous question, we welcome those especially. We don't want anyone to be embarrassed about anything. Please contact us using Facebook Messenger and indicate that you'd like to share your question but remain anonymous. Before we begin, a reminder that this Q&A is meant to be for informational purposes only. If you have a serious health concerns, please consult your physician, and certainly you can make an appointment at the Kaldas Center. Visit kaldascenter.com or call us at 920-886-2299, and we'd love to talk to you and make things better in your life. Remember, no referral is needed to visit the Kaldas Center. Don't let anyone tell you otherwise. From Hannah comes our first question. My husband and I have several holiday parties we've been invited to attend this season. However, I am hesitant as we've been struggling to get pregnant for the last year. I was recently diagnosed with polycystic ovary syndrome, so we do have a game plan. I know family and friends mean well, but what should I say to help them better understand our fertility challenges and my PCOS diagnosis? Thank you for that question. We'll jump right into things, Hannah. And so it's up to you to decide how much you want to share. Some people will be more comfortable sharing their medical diagnoses, others will not. And so a great way, if you want to share, is to simply explain what polycystic ovary syndrome is and what you've learned online that is credible, and what you have what is verified as true information about the syndrome, or what you've learned from your doctor. All right, and so that can help the person understand if you want them to be let into your lives. Okay, but don't be surprised then if there are follow-up questions either at that time or later on. And so it may be, for certain individuals, better to say simply, we're doing fine, today is a good day, and we'll let you know when we have news. And that will hopefully shut them down so they're not constantly asking you, even though most people are well-intentioned, some people are not well-intentioned. And very few of us are good at talking to people when they think that there is something uncomfortable in the air. So, either way, some people need to share with family and friends, and to feel well, others would be better off, especially depending on family and friends. We don't choose our family, we do choose our friends. But, if you're thinking that someone is just being nosy, you might just say, hey, thanks for the interest, but we'll let you know when we have news. How are you doing this holiday season? And then you can leave it at that. It may be disarming to ask about their children if they have children. And so, but that would be very gracious of you, because probably that's the painful subject, to talk about other people's children. And so, but just divert the attention towards them if they're being too nosy, or just let them know that, you don't look for any gossip or news here at this address. Okay? Thanks for the question, Hannah. From Hillary. At my last PAP, I was told I may also have endometriosis on top of PCOS. My OBGYN may want to biopsy a blood blister to confirm. Can this be a way to detect endometriosis? I heard a laparoscopy was the only way to detect it. Well, yes and no. Laparoscopy, by and large, is the only way to detect endometriosis. However, if there is, quote unquote, a blood blister, let's say on your cervix or in the vagina, there is endometriosis that can grow in the cervix, and then therefore it would be called adenomyosis, which is endometriosis of the muscle of the uterus or cervix, and it may even be visible on pelvic exam. So for example, it could be literally growing through the vagina, okay, and it will appear as quote unquote a blood blister, a purple spot in the back of the vagina. Now, mind you, if your OBGYN suggested biopsying that in the office, you may want to be sure to take a little bit of ibuprofen or something, or have them give you something beforehand, because that may not be terribly pleasant to have done, because the endometriosis lesions, especially if they're growing through the vagina, are usually very painful, and they cause usually a lot of discomfort, for example, when you have intercourse with deep inside. And so if they actually see something growing through the posterior fornix, behind the cervix at the top of the vagina is the posterior fornix, maybe it's a good idea to consult with someone who really knows what they're doing with endometriosis, because then it's going to be kind of a bad disease, and you want someone who knows how to resect it without compromising vaginal length or vaginal width, and replacing one problem causing pain with intercourse with another problem that would cause pain with intercourse. You just need to know that's not something a novice should take on, or someone who isn't focused primarily on endometriosis. Thanks for that question, Hillary. And from Becky, what are the success rates for IUI and in vitro fertilization? I have read success rates for intrauterine insemination, depending on the medication used, anywhere between 8% and 20%, Becky. For in vitro fertilization, the Society for Assisted Reproductive Technologies has published recently that per cycle, the IVF take-home live baby rate is 24.7%. And so, depending on the medications, for example, with intrauterine insemination, which really should be done primarily with a medication for controlled ovarian stimulation, such as Clomid or Letrozole or Follistim or Gonal-F, the injectable medications, depending on your situation and depending on where you are in the process of evaluation and treatment of the fertility issue. Most of the time, the injectable medications will be about nearly twice as successful as oral medications with insemination. Insemination alone, without controlled ovarian stimulation with one of those medications, is very marginally beneficial, if at all, for the for a couple. Obviously, if you're working with you don't have a partner, or it's the same-sex partnership, then obviously you're going to be using donor sperm, and insemination obviously will increase your chances from nothing, but it will still work better if you use a medication for controlled ovarian stimulation with the insemination. Okay, thank you, Becky, for that question. And another question from Ashley. I've not had my period now in 2 months, and currently I'm on cycle day 67. I've taken numerous pregnancy tests, all of which are negative. Very frustrating, Ashley. I can feel it. I have been regular 28 to 31 cycle days since before having my daughter and after, and now have no idea what is going on. I have PCOS and endometriosis. I take 3 500 milligram extended release metformins daily. Ashley, I think that PCO can wax and wane as far as the severity of the resistance of the ovaries to ovulation and ovulation induction. And so fundamentally, if you have negative pregnancy test and you have gone 2 months like this without a period, it means that your ovaries are going through a phase where they're a little bit more resistant. And you have to ask yourself if you have lost a lot of weight or gained a lot of weight recently, or neither one. People with PCOS are ultimately, it's in the genes, and it's in the genes of certain cell type in the ovaries. And so we see this where sometimes you're regular when you have PCOS, and sometimes you're not so regular and you'll go for 3 or 4 months without a period. And especially if you're trying to get pregnant, that makes it very frustrating, because it's not going to happen if you are not ovulating. And so then what you want to do is add a medication to help ovulation induction, okay, to help follicular recruitment, in addition to the metformin. Even if the metformin was working great before, it's not that you're becoming tolerant to it, but your ovaries are becoming more resistant, in fact, to the medication. They're becoming more insulin resistant, and therefore you're not ovulating and cycling on a regular basis. That said, Ashley, it must be ruled out that there's another coincident condition that is causing your cycle irregularity, like an elevated prolactin, or like an abnormally low or high thyroid level. And so those things just need to be looked at. It's really easy to figure out. And then it's relatively easy to treat. It's only rarely that we have to go to the point of actually doing like laparoscopy for ovarian drilling for really refractory polycystic ovaries that refuse to ovulate. And so that is what I think about is the best way to go for you, Ashley. Thanks for that great question. And a reminder, if you would like to set up a time to speak with us at the Kaldas Center, you can call us at 920-886-2299 or visit kaldascenter.com. We would love to talk with you. So this month I had my follicle scan, and a 5-centimeter cyst was found on one ovary and a nice sized follicle on the other. I'm actually just curious how common they are and what kinds of things cause them, and if there's anything you can do to prevent them. Do they cause major issues with your pregnancy chances? It depends on the kind of cyst, Claire. It is so frustrating when you have a cyst there and we have to not do a cycle or take a month off and suppress the ovaries. However, there are people who have a predisposition to ovarian cysts, and what kind of cyst is it? If it just came up in 1 month, almost certainly it's just a persistent functional cyst that should go away within a month at most 2. But that in and of itself is quite frustrating. That said, we have had many times when, with our patients where they have a hemorrhagic cyst that is not totally gone away, or that is coincident with a good follicle or two during a controlled ovarian stimulation cycle, and we have had them many times get pregnant in spite of the cyst. Think about it. Many people discover they have a cyst when they're already pregnant, and they probably got pregnant while they had it. Not all cysts are hormonally active, and if it's not hormonally active, it doesn't matter. You just got to watch out for it so it doesn't twist on itself, Claire. And so I don't think that necessarily a cyst will cause major issues with your chances in getting pregnancy. It depends on what kind it is, and mainly, is it producing hormones? If it's producing hormones, yes, then it can downregulate the other follicles and all this and all that, but most of the time that is not the case. You just have to be careful for issues of torsion, and then you're going to have to maybe deal with a cyst while you're pregnant. Thanks for the question, Claire. So, from Karita, after an ablation, how often should women have a pap smear? Okay, and I'm presuming, Karita, that you're talking about an endometrial ablation. Okay, so whether someone's had an endometrial ablation or not does not affect how often they have a pap smear. The recommended time interval between pap smears now is 3 to 5 years, assuming you have no new sexual partner, because HPV can be introduced by a new sexual partner, and the high-risk types, and also assuming that you've had at least 5 years in a row of normals, okay? And so now, if you're talking about an ablation of the cervix for prior dysplasia, then you need to get a pap smear, okay, like a cryotherapy or something like that. Then you need to get a pap smear yearly for 5 years until those are normal, and then you can go back to every 3 years, okay? And if you're talking about, I'm sorry for being, maybe too thorough, if you're talking about ablation of endometriosis, though, like burning the endometriosis, which is not a great idea. It's a great idea to take it out, but not very many people are comfortable with that as far as, surgeons. But then that also doesn't affect how frequently you get a pap smear. And it's still recommended that women of reproductive age and menopausal years have an annual pelvic exam independent of the pap smear. So usually I'll tell my patients, hey, we don't need to do another pap smear for 3 years. And some won't show up and for a few years to see me again, in spite of my winning personality. But the key is that we're checking for more than just abnormal cervical cells, when we do a pelvic exam, that's just a pap smear. Are the ovaries doing okay? Are they enlarged? Is there endometriosis? Is the uterus, does it have fibroids? Is that enlarged? And is there issues of prolapsed bladder, prolapsed rectum, things that can affect the quality of a woman's life that can be helped with various non-surgical and surgical approaches, independent of what the pap smear is. But thanks for your question, Karita. So we have an anonymous question. Thank you for sending that in. How long can the HCG trigger shot stay in your system? I am 14 days post-trigger, and it's a very dark positive line. 12 days post-IUI, and pretty nervous about a miscarriage. The trigger shot is not causing you to be having a very dark positive line. If you have a very dark positive line 14 days out from that shot, you have a pregnancy. Obviously, I wish I could congratulate you and say, this is awesome. Obviously, we just want to make sure that it's a viable gestation, but there's reason for serious hope because of recognized pregnancies like this, unless someone has the unfortunate situation of a history of recurrent pregnancy loss or something that can cause that, of recognized pregnancies for most reproductive age women, miscarriage rate is about 20 to 25%. So that means that if you have a positive pregnancy test, and for sure if it's confirmed with a blood test, then in the next day or two, then you have like a 4 out of 5 chance of having a baby, and I'm really happy for you. And so that's awesome. And so I don't think it's a trigger shot. Good news. Tentatively or cautiously optimistic for you. So now from Lisa. My daughter only has half a uterus and only 1 fallopian tube and has been trying to get pregnant for over 2 years. Oh, any suggestions? Oh, Lisa, just have her call the Kaldas Center. And so she has a unicornate uterus, it sounds like, and unless someone has like done something surgical to remove the other half, which would be sad, and so most likely she has a unicornate uterus. She was born that way. Fine, great. And so we have many people at the Kaldas Center with congenital anomalies of the uterus, and they hear all kinds of crazy things about, oh my gosh, that's so unusual. Doctors say the weirdest things, but a unicornate uterus should not, in and of itself, keep her from becoming pregnant. If she's been trying to get pregnant for 2 years, she needs a basic evaluation for fertility as recommended by the American Society for Reproductive Medicine. Is that tube open? We need to find out if it's open. Does she have something else going on? Is there a polycystic ovary situation going on? Congenital anomalies frequently lead to higher incidence of endometriosis, which reduces fertility by over 50%. She needs to be evaluated for all that and all the usual things that if she had just the usual uterus, all right? And so obviously she needs to have explained that what risk the unicornate uterus carries when she's pregnant, but I do not see any reason why your daughter can't become pregnant. She just definitely needs to have an evaluation to figure out why, because after 2 years of trying, then her chances on her own are 1% per month. They are not 0. They are 1% per month. Is it a male factor even? Is it just that she doesn't have anything else going on? And is her partner or husband that is the primary issue? Obviously, all of that needs to be looked at, can be figured out really straightforward, in a straightforward manner, efficiently, not in some haphazard, shotgun approach that will frustrate your daughter and yourself to tears. You can't let that happen, okay? It needs to be a methodical assessment and plan, okay? So thank you very much. And another anonymous question, can you discuss issues with fertility with confirmed adenomyosis and suspected endometriosis, both before and after surgery? Well, that pretty much takes up my entire schooling there now, but I'll try to give it a package there. So with confirmed adenomyosis uteri, there is debate and real disagreement as to whether that contributes to infertility or not, okay? And so adenomyosis uteri is simply endometriosis of the muscle of the uterus. In my experience, having done, I don't know how many thousands of surgeries now, something around, 6, 7, 8,000 surgeries on endometriosis, I would say that sometimes they're contiguous, meaning that if I see adenomyosis on the ultrasound growing through the back of the uterus, for example, 9 times out of 10, you're going to have endometriosis right there on the ligaments going into the uterus, right behind that adenomyosis, and then outwards into the pelvis, all right? And I heard a recent talk by Dr. Redwine, who was a wonderful pioneer in endometriosis treatment. He had the first endometriosis treatment center dedicated to treatment of endometriosis back in 1988 in Bend, Oregon. And as you may know, Nancy of Nancy's Nook was his nurse at the time. And as I've learned, that amazing site has, over 80,000 followers now. And it's been a huge godsend. But I'm getting off here on a tangent. And so his hypothesis that sure rings true is that there are tracts that are embryologically determined in a woman's pelvis where endometriosis happens. And they are genetically predetermined. And it's a great idea to find out, if someone has endometriosis, if they can wait until after 25, because they are more likely to exhibit themselves. And then when you excise the endometriosis, it is less likely to come back, okay? Now, endometriosis in and of itself outside the uterus reduces fertility by over 50%. The literature is real clear. If you do excisional therapy, removing it without, doing harm to the ureters, without doing harm to the major vessels of the pelvis going to the legs, without doing harm to all kinds of nerve structures in the pelvis. And that's why, so if you actually take it out, because everyone's all worried about doing that, but you just need to have someone who knows how to do it. And then you increase your chances of becoming pregnant to 80% after that surgery for the first year, 90% within 2 years. Abundantly clear, all right? And so in and of itself, adenomyosis, unless you can't find any other thing causing your fertility challenges, is not, I don't think, the main culprit of the fertility issues. Unless you've got some huge adenomyoma occupying the entire back wall of the uterus, then I do think that kind of chronic inflammatory reaction with the swelling associated within the wall of the uterus is probably not a great thing for sperm and egg getting together and implantation. But most certainly endometriosis outside the uterus will contribute to fertility issues. Thank you for that question. Great question. Hey, a reminder, to speak with us, you can just call us at 920-886-2299 or visit us at kaldascenter.com. No referral is ever needed. From Lindsay, does weight play a factor in infertility when you have PCOS? I've heard many doctors only accept you if you have a certain BMI. Boom. Weight does play a factor, Lindsay, okay? And we think that everyone is God's child, and we are not going to be presumptuous enough at the Kaldas Center to tell people that they need to be a certain weight. If you understand, that there are higher risks with a higher BMI when you are pregnant, then and higher risk of diabetes for the child and all that, macrosomia and all that, then we are going to help you achieve your fertility goals. However, a caveat. In 23, almost 24 years of doing this at the Kaldas Center, right, of doing this in Northeast Wisconsin, I have not had a single success for someone with a BMI over 53. That is the highest we have had. And I am very forward with my patients about that. And so there is something that is going on that is preventing conception when you have a very high BMI. And we will try for people, telling them that our chances are lower. We're not going to try. However, if you're having a really refractory situation with a BMI over 50, because we've had many in high 40s achieve success with treatment, evaluation treatment with us. But if it's over 50, you may seriously consider doing a bariatric surgery, because after that, you probably won't even need fertility medications to get pregnant, because your ovulation and metabolism is so dramatically altered and improved that that is just to help you get pregnant. I never tell people to do it just because for the sake of losing weight. I'm one of these people who thinks, like I said, we're all God's children, and I do not. This is no judgment zone at the Kaldas Center. Thank you for that question, Lindsay. From Hillary, does a laparoscopy to remove endo help relieve symptoms? Yes. Just in a simple, it needs to be, though, removal of endometriosis. So last week at the American Association of Gynecologic Laparoscopists, there were just some amazing surgeries that were on video, and you really do need to just be able to get it out. So if it's deep down next to the rectum, you have to know what nerves and structures are there, and you have to know how to get it out without putting a hole in the rectum, without burning the rectum, without getting into major vessels, without getting into nonsense. And so, for example, one of my 3 surgeries today, I took out a nodule of endometriosis next to the rectum. Well, as I was removing it, I said, hey, this thing looks like it goes deeper. I thought it only went 1 centimeter deep. Well, it actually went about 2 centimeters deep, and I could tell. So then I went around it further, but I knew I was getting closer and closer to the rectum, behind the where you can see. And so there are certain techniques you can do to avoid injuring the rectum, and that's what I did, to get the whole nodule out, so I don't just bury something in deep scar tissue and give the person grief down the road. So laparoscopy to remove endo definitely helps relieve symptoms if it's done properly. Thank you, Hillary. So Nikki has a question. With 1 functioning fallopian tube and a low AMH level, is it still possible to get pregnant? Yes. So it depends on how low the AMH level is. 1 functioning fallopian tube reduces fertility by 10%, not 50%. And we all know many people, maybe don't, I do, who have only 1 ovary or 1 tube, have 5 children. And so, yes, you can get pregnant with 1 tube. However, the AMH level, that needs to be evaluated further. What's your FSH level on cycle day 3? Does a Cloma challenge test need to be undertaken to see if you have ovarian reserve? How are you going to respond? And what is that antral follicle count? That would indicate, how likely you are to become pregnant. I can tell you, Nikki, that I have had a few patients with an AMH level of 0.3 become pregnant, but I have not had any success with the 0.1s and the 0.2s. And I definitely had a great many, we consider low between with less than 1.5, a great many less than 1.5 become pregnant. So yes, it is possible for you to get pregnant, but I need to fill in the details, like how old are you and exactly what is the AMH level and what was that FSH level on cycle day number 3 and so on, which is all very easy to figure out. Give us a call if you like. Thanks for the question, Nikki. Wow, it looks like we're out of time tonight, and we have hardly talked about the holidays. We talked endo, we talked AMH levels, we talked polycystic ovaries, but it's all part of who you are, and therefore it's part of the holidays for you. And if you ever want any advice or on how to deal with anything, you just give us a call. If we did not get to your question, we'll follow up with you in the next few days. And a quick reminder that if you'd like to speak further with us, visit kaldascenter.com and give our office a call at 920-886-2299. Happy holidays!